Excellent. Welcome everybody to today's webinar. This is the topic today is about the cost of delivering malaria vaccine, the RTS S malaria vaccine in 3 different implementation countries. Our guest, our presenter, is Ranju Baral, who's a health economist at PATH's Center for Vaccine Initiative Center for Vaccine Innovation Access. And her work focuses on conducting economic analysis of public health interventions. In today's talk, she's going to be talking about a malaria vaccine which is being piloted in 3 countries, Ghana, Kenya, and Malawi, as part of a multi-country coordinated evaluation. And today she's going to focus on the methods and interim results from the costing study part of this evaluation that estimates the introduction and delivery costs for RTS malaria vaccine within a routine immunization program in subnational areas of the pilot countries. And so without further ado, actually, just a couple floor rules or ground rules. Usually if you've come to these seminars before, you'll know that we usually let our guest presenter speak for 30 to 40 minutes, and then we'll have about 20 minutes left for discussion and questions. And you are welcome at any time to type a question into the chat. You can also, when we get to the discussion section, I'll remind you, you're welcome to raise your hand through the Zoom feature of raising your hand. And I will then moderate the discussion, and typically taking people in the order that they raise their hands. So with that said, and another question that's often asked is this going to be recorded, and are the slides going to be available? And typically we do post the webinar recording and often the slides along with on the website. So the recording will certainly be available, and if Ranju is willing, then we'll post the slides as well. And so with that, let me turn it over to you, Ranju, to present. Thank you.
Thank you, Stephen. And hello, everyone. Good morning, good afternoon, good evening. Thank you for joining us today, and special thanks to the organizers for putting this excellent series of webinar, which I personally thoroughly enjoyed over the last couple months. And thanks again for the opportunity to share our work at this session. So today I'm going to present the work that we did with a large group of collaborators, and I'd like to start by acknowledging the contributions from each of the collaborators within the MBIP, or the Malaria Vaccine Implementation Program, Pilot Program Initiative. It is a collaboration led by the WHO with a lot of different other collaborators, which include the other partner organizations, funders, and the country, the immunization programs, ministries of health, etc., and many, many more. And particularly, I'd like to call out for this particular work, it was a joint analysis that we did along with the ministries of health, the EPI programs in the 3 pilot implementation countries, Ghana, Kenya, and Malawi. And I'd also like to acknowledge the contributions from the country WHO and PATH office colleagues for providing and collating all the expenditure data and activities related data, and working very closely with them. And also the Levin and Morgan, who helped develop the costing tool that we use to aid the analysis. So here's an outline of the talk today. First, I will provide a brief introduction of the malaria vaccine implementation program, which will provide a little bit more of context for the costing study. Then we'll go over the costing study details around methods, approaches, and data that we use to inform the analysis. And then we'll spend some time looking at the findings. And finally, we'll conclude and follow up with the question and answer session. So first, the background on the malaria vaccine implementation program. The RTS malaria vaccine was developed over the last 3 decades with its discovery back in early 1980s, and after which it followed many years of clinical trials and testing. Specifically between years 2009 and 2014, RTS underwent rigorous testing through the large-scale phase 3 trial in 7 African countries. And following the completion of that phase 3 clinical trial in 2015, the vaccine received a positive scientific opinion from the EMA, or the European Medicines Agency. And in 2016, the WHO recommended a pilot implementation of this vaccine in select areas of sub-Saharan Africa, following the joint advice of the scientific advisory bodies, namely SAGE for the immunization and the Malaria Policy Advisory Group, MPAC. The 3 countries, Kenya, Ghana, and Malawi, were then selected to participate in the pilot program. And these countries began subnational implementation of this vaccine back in 2019. The main objectives of this pilot program were threefold. First, to assess the safety of the vaccine with the emphasis on the signals that were seen in the phase 3 trial. Second, to assess the impact, especially on the mortality and severe malaria in the routine use settings. And thirdly, to assess the feasibility of reaching the children with full dose of vaccine between the ages of 5 months and 2 years of age, and to determine how best to deliver this vaccine that requires full doses within the routine setting. And the costing study that we'll delve into today fits into the feasibility assessment dimension within the pilot program. Just also wanted to mention that there were 2 different dimensions or the components, I would say, for the pilot program. One was the routine providing vaccination through the routine implementation. And second important component was the evaluation component. And for the evaluation purposes, the vaccine introduction was randomized and introduced in the select areas subnationally, which you can see in the map here. The pink areas, the pink highlighted areas are the ones who provided vaccination during this pilot implementation, and the green ones are the non-vaccination or the comparison areas for the evaluation purposes. In Malawi, the introduction happened in 11 different districts, and the areas within these 11 districts were randomized to vaccinating and the non-vaccinating areas. In Ghana, we had 7 regions within which 42 districts were implementing or providing the vaccine. In Kenya, the vaccine implementation occurred in the 8 western counties in Kenya, and we had 26 sub-counties within those 8 counties providing the vaccine. And just to remind, as of June 2021, there were more than 2.1 million doses of the RTS vaccine that were administered, and more than 740,000 children across the 3 countries received at least 1 dose through the routine immunization programs. And in last month, in October, the joint SAGE and MPAC reviewed the evidence generated from the evaluation component of this pilot implementation and made the recommendation on the RTS S for the use for the broader use. So now moving on to the costing study itself. So although the RTS was being delivered through the routine system, the delivery required at least 1 additional new visits in these countries, and it included a slightly older age group that is vaccinating in the 2nd year of life as well. So understanding the cost of RTS delivery was therefore important to assess the affordability as well as the feasibility of implementing this vaccine, and to understand basically the economic feasibility of the vaccine rollout more generally. So with that, the key objectives of this costing study was to estimate the incremental or the additional cost of introducing and delivering this vaccine within the routine immunization program during the pilot implementation. And we also looked at the cost drivers of this vaccine delivery during the pilot implementation. So here's a brief snapshot of the methods that we used to inform the costing. So the costing was a retrospective analysis where we used the actual expenditures and the resources that were incurred for the program implementation during the pilot implementation in each of these 3 countries. We took a government's perspective for generating the cost estimates, and as we know that the direct expenses that were incurred for the vaccine introduction and delivery were supported by different donor agencies and partner agencies during the pilot implementation, but they were seen as the financial cost to the government, as these costs are expected to be, excuse me, borne by the government under the routine implementation. And we excluded the research specific cost and only included the expenditure that are commonly implemented within the routine vaccine introduction. We looked at only the incremental cost of it is not a full costing, but we considered only the additional cost of adding this RTS S vaccine into the routine immunization program. We followed an ingredient-based and activity-based costing approach where each activity were identified associated with the vaccine introduction and delivery were identified and costed individually. And those activities, sub-activities were regrouped into the standard cost categories, which include, for example, planning, coordination, communication, social mobilization, training, procurement, etc. And the costs were categorized into the introduction or the initial setup cost and the recurring cost. And for the introduction cost, we included the value of resources that last longer than a year, and they include the cost of capital resources as well as the non-recurring activities such as initial training, social mobilization, the development of the communication materials, etc., that had a life year longer than a year. For the recurring cost, we included the value of resources that last less than a year, and they primarily include the cost of vaccine procurement, immunization supplies, vaccine distribution, service delivery, monitoring, supervision, etc. We estimated both the financial and the economic cost to the government. And financial costs include the direct expenses incurred for the vaccine implementation. As I said before, the expenses supported by the partner agencies, the non-research components, were considered as financial costs to the government. For the economic cost, we included the financial cost as well as the value of the opportunity cost of resources, particularly the cost associated with the staff carrying out the introduction activities, and were included in addition to the economic cost. And a few words on the capacity considerations. So there were capital investment needed to fill the capacity constraint for the pilot implementation, and they were all captured as full cost to the program and included both as financial as well as the economic cost. And those some of those costs include expenses on the the cold chain expansion, the waste management system installation, the installation of the incinerators, etc., as well as some logistical support to the EPI to fulfill the capacity constraint at the time. And to account for the incremental resource requirement for distribution, we use the shared inputs that were existing within the routine EPI and allocated the shared inputs based on the direct allocation as informed by the EPI as a certain percentage in each country. For vaccinators, their contribution to RTS's introduction was estimated based on the time that they spent to administer the vaccines. And for all the other resources, we assumed the spare capacity in the existing system to accommodate the malaria vaccine introduction. Some more details on the costing. So we did for the capital cost, they were annualized and over the respective useful life years. And for the introduction and the initial setup cost, the costs were annualized, and for the economic ones, they were discounted over the period of 3 years, which was assumed to be the useful, the life of the pilot implementation. And all the costs are reported in 2020 USD currency units. So here is a costing tool. As I mentioned before, we developed a costing tool developed by Levin Morgan in collaboration with the WHO. So this tool was used to aid the analysis, and some of you may already be familiar with this kind of a tool developed by the same Levin Morgan, which include tools like the C4P tool for costing, the HPV, the flu tool, and etc. And the tool takes the government's perspective and captures all the different cost categories that I described before. So for the data, the expenditure data on each of the activities that were implemented in each country during the study period were collected separately from each partner agencies who were leading or contributing to that activity. The detailed expenditure resource use list were extracted from the expenditure reports and activity reports that were prepared upon the completion of the activity by each representative organizations. And that was particularly useful in identifying the staff categories who were involved in the resource use and to quantify the resource use. And in some cases, when the actual expenditure reports were not available, we used the disbursement reports to quantify some of those detailed cost, and it was especially valuable when we were trying to value the opportunity cost of staff and to allocate the expenditure across subcategories. We also collected primary data from a representative sample of health facilities within the pilot implementation areas and the data collection was done in 2019 and part of 2020. And this primary data specifically were used to inform the recurring or the operational cost of delivery. For example, the frequency of the distribution of various, these commodities across different levels, and the detailed resource use for that purposes, the delivering the vaccine, the time taken to deliver the vaccine for each vaccinators, etc., etc. The data on the target population came from the pilot implementation annual reports, and for the the analysis, we used the data through the end of 2020. Now, just to remind, the pilot implementation began in April of 2019 in Ghana and Malawi, and in September of 2019 in case of Kenya. There were a lot of activities that had happened in the preparation of the pilot implementation in 2018. So we accounted for all the major activities and costs incurred from, in 2018, 2019 through the end of 2020 in this analysis. Now, this is a very, very busy slide, but I think an important one, which describes the key inputs that were used to inform the analysis. And so first, looking at the demographics of the total target population during the period of 2019 and 2020, for those many months that the children who were eligible, we had for Malawi around 250,000 children who were eligible for receiving this vaccine, Ghana 283,000, and in Kenya 191,000. And the last number of children in Kenya is again reflective of when the program actually began, 5 months after the other two countries in Kenya. The total doses administered are there, which is roughly at 490,000 in Malawi during that period, 540,000 in Ghana and Kenya. The coverage as a percentage of surviving infants, you can see for the first 3 doses, it ranges somewhere between 70 and 80% for across the 3 countries. And for the third dose, it ranges roughly between 50% and 55% across the 3 countries. Now, looking at the coverage of the 4th dose, this is, you can see that it is less than 2% in Kenya and about 5% in Malawi and Ghana. And that is reflective. It's not the actual coverage of the 4th dose, but it is an artifact of the fact that the many children who were eligible for the 4th, who were to receive 4th dose were not yet eligible at the end of 2020, and therefore that. So it's not the actual coverage, but just the artifact of the duration of the analysis that we considered. For the product cost, again, the product is not available in the market and don't have a product price, but we use the standard, number that has been used for this particular vaccine in the literature, which is at $5 per dose. And we also considered a range of vaccine prices in different scenario analysis between $2 and $10. And the cost of syringes, the immunization, other immunization supplies, you can see there, which were informed by the actual cost for those items during the pilot implementation. For the procurement add-on cost, again, they were derived from the pilot, what was observed during the pilot implementation, and these were calculated as a percentage add-on to the base vaccine price assumption. So basically, as you can see, there's quite a bit of difference across the 3 countries. The procurement add-on, which include freight, insurance, and handling, and etc., accounted for like about 21.5% in case of Malawi, and roughly 11% in Ghana, and about 7.5% in Kenya. And those costs were added on to the base cost per dose. And next, we also accounted for the wastage, potential wastage and buffer necessary for the commodities. And for the vaccine service delivery, we derived that data from the primary data that we collected. And as you can see, there's quite a bit of variation in the reported time that they would spend on vaccination, ranging from 6 minutes in case of Malawi to up to 14 minutes in Kenya. Now, moving on to the results, the key results. We call it the interim results again because, as I mentioned before, it includes only the data through, for about 15 months for Ghana and Malawi, and 20 months for Ghana and Malawi, and about only 15 months for in case of Kenya. And a lot of children were not yet even eligible for the vaccination. And therefore, we will be updating this analysis, looking through, allowing at least 24 months worth of data. So we are currently gathering the data and we'll be updating this estimate. So please, so these numbers that you're seeing here is to be considered as an interim results, which will be updated in the final round. So from the government's perspective, looking at the cost estimates, the cost per dose of administering the vaccine, which basically looks at the total cost during that period divided by the total number of doses that were administered. We have the estimates. The estimates come to around $2.40, 46 cents. And $3.18 across the 3 countries for the financial cost. And the economic cost range between $8.8 to roughly $10.7 across the 3 countries. Now, just to remind that in the financial cost, we did not include the cost of vaccine, and these costs are estimated assuming the base case of $5 per dose of vaccine, and the economic cost includes that $5 plus the financial cost. In the financial cost, what is included is the additional procurement add-on cost, that percentage, and etc. So next, on the cost of delivery per dose, which basically in which we exclude the cost of vaccine product and the immunization supplies, as well as any procurement add-on cost, and include only the non-vaccine cost of vaccine delivery. And looking at the cost estimates, it is across the 3 countries, the cost of delivery per dose was estimated to be around $1.20 to $2.50 for the financial. And for the economic, roughly $2.07 to about $4.70. We also looked at the recurring cost of delivery, which excluding the initial setup or the introduction cost related to the RTS introduction and delivery. And we expect that this recurring cost of delivery would be more representative of the program cost in the long run from the government's perspective. And that recurring cost of delivery is estimated at roughly 40 cents a dose to about $1 across the 3 countries. And for the economic, the recurring cost of delivery is roughly between $1 and $2.60 across the 3 countries. And lastly, we define the fully immunized child as the number of children who received vaccination for all 4 doses of vaccination. But because of the limitations of the data on how many children were vaccinated, we're not able to compute the cost per fully vaccinated child, because as I said, only a very small fraction of target population received all 4 doses at the end of 2020 due to age eligibility. And this will be, we will be updating that and generating those cost estimates in the next iteration. And so now here are some again the results especially on the cost per dose across the 3 countries, and where we're looking at different cost per dose assumptions: $2, $5, and $10. So this the first block is on the cost for the financial cost, which again, just to remind, it excludes the cost of the vaccine, but includes the procurement add-on cost, that different percentage as a different percentage of that base vaccine price assumed. And as you can see, the different colors represent different countries. As you can see, in Malawi, at a $2 per dose assumption, the cost per dose of ranges from $1.75, assuming $2, to up to $3.64 for when we assume the $10 cost per dose. The difference between these 2 is roughly around $2, what the financial cost would be. But if you look into the other countries, say, for example, in case of Kenya, the cost per dose, assuming $2, is around $2.70, whereas that, when we assume a $10 vaccine price per dose, it is $3.36, which is less than $1 difference. And the main factor that is driving this difference is that procurement add-on cost. If you recall, the procurement add-on cost, which is an add-on cost to the base price, is 21.5% in case of Malawi. It was 10.6% in Ghana and 7.6% in case of Kenya. So that is basically what is reflected here. Like, that has an implication on the financial cost to the to the government, especially in this context. And again, even that procurement add-on cost and the implication for the government budget will be determined by what, how the donor programs will be able to contribute and soak up some of those costs. But in this particular analysis, what we've assumed is that the vaccine would be donated and therefore only included in the economic cost, but the procurement add-on cost would be assumed by the governments, and therefore you see this cost. But again, that distribution will be different depending on the financing policies and support from the other agencies. And similarly, on the And also just to mention that for the pilot implementation itself, those procurement add-on costs were assumed by the donor agencies and not by the government. Just wanted to make that clear. And in the second half of this graph, we have the economic cost, which again, as I said, includes the cost of that assumed vaccine price in there. And you can see the differences in cost across 3 countries here. Next here, this slide summarizes the cost share between the initial setup or the introduction cost and the recurrent cost. And as you can see, it is again a busy slide. Let's look only at the financial cost first. And the key message here is that the maroon one is the recurrent cost, and as you can see, the recurrent cost, a share as a percentage of the total cost, is higher, is about 68% in case of Malawi, and that is kind of reverse in case of Kenya, which the proportion between the initial setup cost and the recurrent cost kind of flips to in case of Kenya. And there are mainly 2 reasons for this. First is the capital expenditure, which is included in the initial setup cost in this in the red portion there. If you look into the capital expenditure on the cold chain strengthening and the waste management, which included the incinerator installation, etc., and other logistics support to fill in the initial gap for the pilot implementation, that constitutes a very small fraction in case of Malawi. It was less than, I think it was around 3% of the total cost in case of Malawi. Whereas that initial, capital investment to fill in the capacity constraint constitute around 9% in case of Ghana and 11% in case of Kenya. And those were the full costs that were incurred for the MVIP or the pilot implementation. We considered those as the financial cost, and therefore you see a variation in the cost share. And the second reason is that the recurring cost, again, in case of Malawi, is driven by the procurement add-on cost, which, as we saw before, was significantly higher in case of Malawi compared to the other countries. And in this slide, again, it is showing the same kind of same information, but looking at more detailed cost components. And here we're seeing the total cost drivers of the total cost. Here, this red bar is, again, the procurement, the product procurement cost. And again, telling the same story that the product procurement, when you see the financial cost, it is, excluding the vaccine, but including the procurement add-on percentage, you see the procurement cost constitutes a large proportion of the total cost in case of Malawi and significantly less as a total percentage of the total cost for the other 2 countries. The other major drivers of costs, looking at the financial cost, is the green one is the training. It unsurprisingly, training constitutes a significant portion. The communications, quite a bit on the communications and social mobilization activities were the other major drivers. And lastly, the supervision and monitoring evaluation activities also constitute the other major financial cost drivers. The last bar section here is again on the capital investment, which include the cold chain and etc. strengthening, and again attesting to what I previously described, that it constitutes a smaller fraction in case of Malawi compared to the other countries. And if you look into the economic cost, the service delivery constitutes a reasonable amount of cost of the total cost share. And if you recall, the economic cost primarily of service delivery primarily included the time, the opportunity cost of time that the vaccinators used in providing the vaccine, which again, what is driving this higher cost share is the higher wage in terms of and higher time required for vaccination as reported by the vaccinators in case of Kenya compared to that in Malawi. Moving on. So in this slide, we see, as I mentioned before, we also did some one-way sensitivity to look at the unit cost estimates, the cost estimate sensitivity with respect to the different input parameters. And this particularly is for the cost per dose for the economic cost estimates. And as you can see, the cost of vaccine price per dose assumption and the coverage assumption are the major factors, that lead to the sensitivity of the parameters uncertainty. The other factors such as wastage and the discount rate had relatively very small role in determining the unit cost estimates. So in summary, so here I just wanted to summarize, recap the cost analysis and the estimates. So the incremental cost analysis that we just saw was using, we did this analysis within the setting of the routine implementation in Ghana, Kenya, and Malawi, and we used the retrospective cost data from the pilot implementation between 2018 and 2020, using the cost data incurred during that period. These are, again, from the outcomes perspective, there were still, very few number of children were eligible for the dose for receiving the dose for. So the denominator is significantly smaller in that regard, and so the unit cost associated with the administration should be looked with, we need to have that perspective in mind, and those will likely come down once we are able to account for the additional, the outcomes that were achieved with the investment that were made during that period. And as an assumed vaccine price, just to recap the estimates, the cost per dose of administration were ranged between $2.40 to $3.18 for the financial, and for the economic, we had $8.80 and to almost $11 for the economic. And the vaccine costs were only included in the economic cost, the cost of the product. And these estimates that you're seeing in the summary slide assumes a $5 per dose, again, just to remind. On the cost per dose of delivering the vaccine, which includes the non-vaccine cost of delivery, it ranged between $1.20 to $2.50 for the financial, and $2.40 to up to $4.70 for the economic. And more importantly, the recurring cost of delivery, which is more reflective, we believe, as a long-term cost for the government, ranges somewhere between 40 cents to $1.10 for the financial, and about $1 to $2.60 for the economic. And the initial setup cost, or the introduction cost contribution to the total cost, vary largely across the countries, ranging from 32% to up to 66% of the total financial cost. And as we discussed, the major cost drivers were the procurement add-on cost, and outside of the procurement was training and the communication and social mobilization support activities that led to the, that drove the cost of unit cost of the program. Just to highlight some of the caveats, I think a lot of this we already covered. The one thing is that the interest from the programmatic perspective was that, given that this vaccine is a 4-dose vaccine, and and with some additional touch points, especially on the second, vaccinating children in the second year of life, the question we had was, how much more, or how different is it to vaccinate children in the second year of life and achieving the 4th dose? Unfortunately, for this particular analysis, we didn't have complete data on the 4th dose, but just to caveat that, the introduction cost that we looked at, where were fully loaded, but the denominator was not complete. So just need to keep that caveat as you look into the numbers. And what else? And also the one thing that I've noticed that in this analysis, we looked at the pilot implementation cost, and all the introduction specific costs were attributed to this denominator of the population, so which has the chances of inflating some of the cost, because we're looking only at the subnational implementation. But if it were at a national level, those costs would be distributed over a larger range of denominator, reducing, bringing that cost down. So we will be using this analysis and these cost estimates to sort of project the cost of the national vaccine rollout. And, those are some of the things that we will be taking into account moving forward. So that is all that I had for the presentation. Now, thank you for your attention, and I think we can open up for the questions.
Fantastic. Thanks, Ranju. So everybody, I encourage, if you have questions, you're welcome to type them in the chat, or if you prefer, raise your hand in the Zoom, and I'll call on you if you want to, ask your question live. It looks like we have one question already from Moro Toure, who asks that training seems to be a significant proportion of both economic and financial costs. What is responsible for this? Is it the case that the vaccine is administered differently from other traditional vaccines and also stored differently?
That's a great question. For the training, looking specifically at the training, and I think that relates back to the last comment that I made around, we are attributing all the cost to the subnational introduction. Now, if you think about this training that happens at the national level and all the investment that goes into, generating the training materials and everything, that if it were a national introduction, it would be distributed across a larger population, bringing down the unit costs, unit cost of training down in that way. So I think that is one way that we had captured and used the total introduction cost in the analysis that is inflating some of those training costs. The way the training was implemented for the pilot implementation was we had a cascade training starting from the national level, having different training of trainers, and then training at who go down and then train the people at the regional level, going down to the district level, and then cascading it down to the vaccination areas as well.
And Christina Banks asks, what was driving the much higher financial recurring cost in Ghana, $1.20 versus 40 cents? Were there any contextual factors which differed significantly?
Yes, I think the way that the pilot was implemented and the actual activities that went into the pilot implementation slightly varies by context, in each of these countries. And one of the things that Ghana did, or I recall, is especially around the thinking about the recurring cost of delivery. In addition to the routine vaccine implementation through the existing EPI system in the routine, existing static clinics, as well as from the outreach clinics that they provide the vaccine routinely, they had done some mop-ups and they had some additional investment done to reach out the different pockets, areas, which was not only done for the pilot implementation, that was part of the way that they did in other cases as well, but I think it was enhanced in case of the pilot implementation. So there were some additional mop-up sort of activities, or the intensified implementation that had happened, and the cost associated with that were captured in that, inflating some of those recurring costs.
Anna Hiddle asks, thank you for great presentation. Could you talk more about your data collection? How was it conducted? What was your sampling for data collection at delivery level? Any sensitivities around this sampling and how it may have affected service delivery costs?
So, so great question. So for the data collection from health facilities, so basically we worked with the EPI and the others to sort of, came together and decided from within the pilot implementation areas, we wanted to reach out a representative sample. So there were 11 districts in Malawi, 7 regions, and then I think we had 42 districts in Ghana, and then 26 sub-counties within 8 different counties in case of Kenya. So we sat down with the EPI to select the representative set of sub-counties in case of Ghana, in case of Kenya, representative set of districts in case of Ghana and Malawi. And we had that based on, we went to at only the areas that were implementing the vaccine. So there were, within the pilot, there were like the comparison areas as well, the equal number of comparison districts of sub-counties, etc. But we gathered the data only from the implementing areas. And there were, I think, 24, there were the number of health facilities where we went to gather the data, again, spread out across those number of implementing areas where 24 districts in 24 areas in case of Malawi, about 30 districts in case of Ghana, and then 32 32 health facilities. Sorry, all those were health facilities within within at least 50% of those implementing areas. I know that was rambling. I don't have the numbers in front of me, but we went to at least 50% of the areas who were implementing the vaccine, and then from there selected at least in each of those counties at least 2 sub-counties and a sample of districts based on the proportion of how big the sub-counties or the counties were, and etc. And the other question around how that information was used in terms of inferring the different recurring costs. So there were a lot of information being gathered around the way that they do the deliver the vaccine, and it was at the end of the day what we applied to this analysis was averaged across all those different health facilities where we went and gathered all this data around the time spent on vaccination, the proportion of children who get vaccinated in the static session versus in the outreach session, the cost associated with distributing the vaccine, and how much cost is and the human resources are required to go and collect the monthly collection of the vaccine. And also we also gathered the data from different district level and regional level, national level vaccine depots to understand the cost of distributing those vaccine, and then attributed the shared for the shared allocation, the percentage as informed by their assessment, the EPIs, at all levels, their assessment of what that fraction looks like. So all those information were, used from the around the recurring cost from the primary data. And sensitivity in particular, I think that was a question at the tail end on that. We did send, I didn't include any analysis around the sensitivity, but we looked, I think there was one included on the time spent on vaccination. That has an implication mostly around the economic cost. I don't know if I showed the economic or the financial cost, but we did look into that, and it has some influence, but it's not a primary driver of the when you look at the cost per dose delivered. I hope that answers.
Yeah, just to pick up on that, it seems I was interested in the variation in service delivery time. Because in work we've been doing trying to cost the delivery of COVID vaccine, a big variable in that model is how many minutes it takes per dose. And I was interested that you saw a pretty big variation across the countries, and it since you have primary data from many sites within a country, you could also probably present something that shows the variation from site to site, or the range of, the distribution of answers you get, perhaps in terms of the time it takes per dose to deliver, and to understand better what drives that variation. One thing I was curious about is obviously, the units might matter, because it is it staff person minutes, or is it minutes of the session? Because one way you could have shorter times per dose is to have more people, more employees working simultaneously, right? And so that, I was wondering, whether you considered, measuring the time in sort of person time or worker time.
Yeah. So yeah, that's great, and I think we have gathered the data around both, like the session size and the number of people involved. But to inform this particular analysis, what we had used is the person time, like how many for one person, how long it takes in getting through, from when the child gets into the vaccination session, for reporting, writing, and et cetera, through, the delivering the vaccine, and et cetera. And those were, it's not the time motion study, which would have been a better, to get the actual insights, but those are like reported. And in some cases we were able to sort of, observe and sort of do the validation. But again, that range might have, across the different health facilities and different, counties, anything. I think it'll be an interesting idea to look into, like, what are the factors that are driving some of those time, the way that they're reported, and et cetera, and look into, how that impacts the cost. One, that would be, I think, would be separately, we could look we did not calculate the cost per dose at the facility level, so we might not be able to sort of look into that, how that impacts the cost per dose itself, but use that information to sort of do that sensitivity, and just looking at, what are the factors that are driving, their reporting of the number of minutes, definitely.
There's a couple questions here from Ava and Bazant, and then someone else, SY Aber, who are asking about vaccination strategies. And I think you had a situation where it was in the routine program, but there was an outreach component. But there's a question as to whether there was any thought to, in the future, estimating the cost of delivering malaria vaccine in campaigns, along with another vaccine or intervention, such as bed nets, to look at cost sharing.
That's a great point, and perhaps potentially we, of interest, if, depending on how countries decide to roll that out, and if they decide to go out in the campaign. I don't think we have done, we have not done this for this particular analysis. And the reason behind that is that, for the pilot implementation, one of the major objective here is to understand, not to generate a new system of vaccine delivery, but to have it embedded within the existing routine implementation in whatever ways they are doing, the countries are doing or delivering the traditional vaccines. For the RTSs, we did not want to create another parallel system for campaigns or etc., but to have it as a part of the routine implementation, and to understand basically what it cost additionally, if there is any additional, what is the extent of the additional cost that is needed. So that is the context in which we generated this data. Now, said that, not within the context of this pilot implementation, but there are some other clinical trials and studies happening where the RTSS is being delivered along with other interventions, say for example the seasonal malaria chemoprevention and etc. So we are actually doing it's a separate analysis, but we are currently looking at that specific questions of how can what would be the cost of delivering RTSs along with another intervention, in particular the SMC, in if the countries decide to do it in a campaign way or within the existing routine system. So yeah, I mean, there is definitely that interest in looking into that cost share and how different it would look like, but it's out of scope for this particular analysis.
Thank you. It looks like Ijeoma Edoka has a question, and I wasn't sure I understood it. And so maybe she can ask live. I think it refers back to one of your slides.
Thanks, Steven, and thanks, Ranji, for very interesting presentation. I just wanted to, I was just curious to know, one of the slides you had service delivery costs as a driver of financial costs in one of the countries, and I just was curious to know that slide in Ghana, yes.
Yeah, so this one.
Yeah, what was driving that? Yeah.
That's a great catch. And the reason that we have observed it only in Ghana was for the same reason, that there were like additional, support on the allowances to support this additional mop-up kind of activities that were done in Ghana, which were considered as a financial. So there were some allowances to carry out those additional activities outside of the the routine static and the outreach clinics, and that is why you only see that in Ghana and not in the other countries.
I wonder if I might ask another question. I think several years ago, I think it was PATH that was involved in some pretty rigorous costing of HPV vaccine delivery in different pilot countries. And I know that those are still data points that we look at today when trying to answer questions about how much HPV would cost to deliver. But there seems to be an impression among most people who look at those estimates now and say, oh, the cost estimates in those pilot studies are way higher than what it actually costs in a routine context. And I wonder if you guys either took lessons learned from that earlier work on HPV, or whether you think that the data that you're finding ought to be adjusted in some way, given the fact that it's collected during a pilot phase study.
Yeah, that's a great point, Stephen. And we, as I mentioned early on, this was supported by different donors and was done within the pilot setting. And no matter how much we try to adjust, I think there will still be some reflections of the typical notion of the pilots are usually expensive and etc. But given that we did this analysis from the government's perspective, we did very thorough we at least sit down with the EPI and all, looking at each of the specific sub activities that were included into this, and made the diligently sort of crossed out the activities or the sub activities that were reflective of the pilot and that wouldn't occur in the pilot setting. So we had a multiple set of iteration with the implementing agencies, the countries, and hey, this activity, would you do this in the non-pilot setting? And so we have done that, and I think said that I think there will still be some aspect. We will be updating this analysis again and have an opportunity to sort of go back and then look into those specific, if there is any, to sort of sort out, so that this information can be useful and as reflective of the long run the government cost as much as possible.
That's great.
And we try to take out all the research specific cost, because research and evaluation was one major component of the pilot implementation as well.
Thanks very much. I think we're at time, so we perhaps will leave it there and say thank you for your presentation and being willing to do this today. It was really interesting. And I'll just point people to the next webinar will be November 17th. It'll be at 8 a.m. Eastern time. So it's at a different time slot. And that's Katarina Hauk is talking about optimizing pandemic responses. So thanks again.
Thank you
All
all.
right.
Thank you very much for the time and attention, everyone.
Yeah, it was great. It looks like we had a peak of about 47 people. So really good.
Awesome. Thank you.
And
Thanks.
and that doesn't even count that for Bruce Larson at BU was showing the webinar to his class during his class time. So there was even more people. So that's great. All right.
Thank you, everyone. Bye.
And Mauro, thanks for the feedback about accessing the slides. We'll work on that. I appreciate the feedback. All right. Bye-bye.